If we look at the big picture, you've got a few ways to treat epilepsy. You've heard about several of them. The mainstay is medication, drugs. Another would be alternative medications or alternative approaches. You heard a little bit about that. There's ketogenic diet. It was mentioned. It's been questioned. Not too much detail on that. But then you also have surgery and devices. So let me kick off this panel by giving a bit of background on epilepsy surgery and epilepsy devices. There are two things I want to say by way of preamble. One is that the surgical procedures I'll talk about, for the most part, are available now, and some of you have had them. The devices are experimental, with the exception of the vagus nerve stimulator. They're not yet approved. We hope, at least not in the United States. We hope that some of them will be approved in the near future, but certainly not all of them will be. So please don't expect me to be able to give you a list of where you can have what I talk about in the last half of the talk produced for you. And then secondly, I'll just be brief about it, but I have associations with a number of the companies, even though I'm 99% a professor and treating clinical doctor. 1% so far, without any generation of income, by the way, is consulting for companies. So that generates a conflict of interest, and you have to treat me as a 1% company salesperson and a 99% doctor. So the most common surgical procedure is a temporal lobectomy, and you see in a cross-section of the head here, you see the eyeballs, and you see a white spot on the right where the temporal lobe used to be. Who would be a candidate for this sort of operation? Well, first, you would have to be not responsive to medications, because if it can be handled with drugs, you don't want to go through the potential risks of brain surgery. We can always switch the drugs around if we don't like it, but once we've taken out a piece of the brain, you can't put it back. Secondly, we need to know very precisely where the seizures come from, hopefully in the tip of one of the lobes, like the temporal lobes, where it's accessible, and that should be the only spot where they start, because we can't go removing multiple different areas of brain. And by the way, about 2 out of 3 people do respond quite adequately to the medications. I doubt that that's 2 out of 3 people in this room, or you wouldn't be here. But in general, among people with epilepsy, that's the case. So temporal lobectomy is our favorite procedure, and I could spend a whole hour on that, but I'm just going to give you a very quick overview, and then you can question what you want to know. Secondly, and most usefully for surgery, is the set of procedures called lesion removal, L-E-S-I-O-N. Not legion, but lesion. So what a lesion is something that looks abnormal on an MRI or a CT scan, but we don't necessarily know what it is. In this case, circled in those red dots, is a vascular malformation, capillaries that has caused a little bit of bleeding in the brain, irritated the brain, and made seizures. Now, if you have something like this, you put a scar on the brain and it leads to seizures, but it doesn't mean that every time you have a seizure it's bled again. It may just have bled once and irritated the brain, and then the seizures keep coming back. So if we can identify that by MRI, and the EEG shows that the seizures come from the same place, cutting that region out, a little surrounding brain too, will very often solve the problem. And that so-called lesion could be an abnormal blood vessel, it could be an old stroke, it could be some type of a brain tumor, but usually it isn't. It could be a birth defect in the brain called a dysplasia. It could be an old traumatic scar. Anything that puts a scar on the brain can cause seizures. Here's an operation called Corpus callosum resection, what one of my Baltimore patients once called that colossal operation. It's also called the split brain operation. The corpus callosum is a band of fibers that joins the left and the right side of the brain, and seizures can flash from one side to another. So you see the first half on the left side of your screen, cut. It's black instead of the normal white color because it's been removed. And that makes it harder for seizures to spread quickly. I think of it not as a procedure to stop seizures so much as to stop falls and injuries from seizures. It's not nearly as commonly done as the two procedures that I talked about previously. Now, those of you who are a little squeamish, feel free to close your eyes because you're actually looking at a human brain during surgery on which we've placed electrodes. This is not your grandmother's EEG. We don't do this in most people. We only do it where we think somebody is an excellent candidate for surgery, but we have extremely little margin for error in terms of removing the seizures near the speech area or the motor areas. And then we may implant electrodes under anesthesia directly on the surface of the brain to map exactly where the seizures come from and where in relation to other critical areas that we must not remove. So this is called, I don't like the term, but it's called invasive surgery, like we're invading some country. We need a better name. So those are, see, the slide advancement doesn't work very well. Anyone know if there's a place I'm supposed to point it? Good. Okay. Now we start moving from the present to the new and soon to the future. Here we're talking about something called stereotactic radiosurgery. This is radiation to shine on the brain. Radiation damages brain, and it's another way of removing it other than a surgical scalpel. Ordinary radiation damages the brain in passage. So you don't want to do that because there's usually healthy brain between where you want to remove. But the newer types of radiosurgery called gamma knife or cyber knife can, for example, spin this robot head around so that only the intersecting area in the middle gets a significant dose of radiation and a hole is burned at that point. It doesn't even require opening the head to do the surgery, and it's a single treatment. So it seems much more convenient. On the other hand, radiation often has long-term side effects with some late breakdown of the tissue around where you radiated. So jury is still out on whether this is long-term safer than doing an operation all at once, but it is in clinical trials led by the UCSF group right here in San Francisco. And I was also asked by someone to mention, and I will, the Visualise laser that I really just mostly learned about yesterday in the presentations. This is a little needle that is placed by computer guidance into an area you want to operate, and then it generates heat, and it very precisely burns out that region of brain, and you take out the needle. So it is invasive. You have to make a hole in the head, but you don't have to do a big operation. See, operations all have side effects. Drugs do too, but they can be more serious for the operations. And in general, about 1 out of 50 people have a serious side effect from surgery. And you can tell us more in a little bit how you put all that into the equation when you made your decisions. So now we move on to things that are in the future, devices for epilepsy that may be coming down the pike. I'll just mention them to you. I won't go into detail. One is a type of notification device. You just heard about a bed shake monitor. Another possibility is a watch. This isn't one, but to illustrate, a watch that has a 3D accelerometer in it that picks up the shaking having to do with seizures. There are 2 such watches being developed. The one on the left is going to be released probably for public use in about 2 months. It is a notification device to cell phones, and it also sends a GPS signal about where, let's say, your child is having a seizure. But it only works for seizures that involve considerable shaking. It won't pick up the little staring, complex partial non-movement sorts of seizures. I hope that someday soon, these devices that will automatically detect seizures, such as shaking devices, will communicate them to your online diary that I hope you'll all start to use, such as the Epilepsy.com diary, so it can automatically keep track of when you're having seizures, how long the seizures are. And if you really want to get fancy, and you're really technology-oriented, you can also get various pill dispensers that tell you when to take the pills and record when you take the pills, and you can have everything documented. Now, it seems a little bit for the iPhone set, but I have an iPhone on my belt right now. I am the iPhone set, Palo Alto. So I'm pretty convinced this is where chronic disease is going, that your blood pressure will be automatically online and your blood sugar if you have diabetes, and we should be part of that movement with epilepsy as well. Well, I don't know if I can go backwards or not. Yeah, good. How much different seizures would be if you knew that your next seizure was going to be 5 p.m. Tuesday? You know, if you have one seizure a month that lasts a minute, I calculated that that's 1/40,000th of your life. How can something that is 1/40,000th of your life ruin it as much as seizures do? There are a lot of answers to that. There are the meds, there's the social stigma, there's long postictal state. But most of my patients tell me that the big problem is that they don't know when that minute is going to be. So any minute is a minute where you could have a seizure. Well, I'm happy to tell you that a company in Seattle called NeuroVista has developed a little implantable chip, and it does need to go under the skull bone, not into brain, but under the bone, that then connects like a vagus nerve stimulator with a wire under the skin to the chest that monitors your brain waves and is aware when they change in a way that makes it likely for you to have a seizure within the next, say, 15 to 60 minutes. And it then broadcasts a color signal to your pager. So blue is good, and red means you're likely to have a seizure. And although this seems a little bit science fiction-y, it's been tested so far in 15 people in the first clinical trial in Australia, and with a few months of use, nobody's had a seizure without the red, a grand mal, a tonic-clonic seizure without the red indicator being on. So it may be possible sometime in the near future to predict and anticipate your seizures, and then only you can decide how that would make your life different. One thing you might do is sit down or get out of an embarrassing potential situation, but ultimately you might be able to take some quick-acting therapy and head the seizure off. This is a cooling device. When electric currents go through that, one side becomes cool, the other side becomes hot. I've done some experiments in laboratory animals, not people, to cool the seizure focus reversibly and just shut it off briefly. It may become a treatment, but it has some technical issues to still iron out. This shows in a laboratory model in my lab in a rat spikes. Spikes are things that look like gee, I really don't like this pointer at all. Well, they're the pointy things in the top two channels and the bottom two channels. And in the middle, it's cooling the brain, and the spikes go away when you cool the brain. Nice thing about that, it's fairly quick and it's reversible. But there's something that's even quicker and cooler that's just come on the horizon, and that's a new area called optogenetics, which I think most of you probably would not have heard of. It's so new. And I'm proud to say it was invented at Stanford, sadly not by me. I wish I had. There are these little bacteria that live in very salty lakes like the Dead Sea, or in this case Lake Zug in the Sahara Desert, that have all these salts that they have to pump out constantly, so they use the energy from light, as they would with photosynthesis, to open ion channels in their cell and pump the stuff out, and they've become very efficient at pumping out ions. Well, brain cells govern their excitability by what ions, like sodium, potassium, chloride, calcium, are flowing in and out across the membrane. So Carl Diceroff, a researcher, took the genes to make these ion channel modifiers and stuck them in brain cells by using a virus to put them, a friendly virus to put them in the DNA of the cells. This is a type of gene therapy to put the genes in. And so you can now dial in with a pulse of light whether a brain cell is excitable or whether it's inhibited by using, in fact, different colors of light. So I might imagine a day, not tremendously far in the future, might even happen before I can change to the next slide. Thank you. I think if I call for next slide, will you just do it for me? Thank you. So here you have a brain slice, not from a human, but you have in the top row a buzz of a seizure when you shock the input to the tissue. And then in the second row, you do the same thing, but while shining an orange light on top of the slice, and it completely blocks the seizure. And the bottom row is doing it again without the orange light. Now, this is a little invasive. We'd have to inject viruses into the head around the seizure focus. It's going to happen, not next year, but as we perfect gene therapy, the first gene therapy experiments are coming out successful now. So far, not for too many neurological diseases. And then you'd have to have a light fiber, but we're talking about flipping a fiber optic light switch and instantly shutting off the seizing brain cells and inhibiting them. Optogenetic devices, it's called. Next slide, please. This is another technology which involves squirting seizure drugs directly onto brain. If you have one spot in your brain that's part of a seizure focus causing the problem, why do we have to soak your whole brain and your whole body in drugs that give you kidney stones, nausea, low white blood counts, rash, cosmetic effects? So the notion is, can we put in a little mini pump and a little tube and just squirt the drug directly on the spot in the brain? This shows doing it in an experiment in a rat in my lab where we used diazepam, Valium, not a drug that I would ever want to actually squirt in a human's brain, but it was good for experiments. I'm trying to get the cursor. Can't do it. If this thing has a battery, it might need a new one. So why don't you do it just for future speakers? I can't be saved. So you see on what looks like a little timeline, you see little bars. Those are spikes. And then you see where vehicle is injected. Vehicle is control. It means the computer program detected a seizure and gave a little spritz of drug onto the brain, but it was control, so it didn't stop any seizure, and you see another line where more seizures occur. On the bottom where it says diazepam, which is Valium, it was real drug in the pump, and the spritz just completely stopped the seizure activity. Next slide, please. That was in an animal. I can tell you we're now about to launch trials within the next year of delivering drug to the brain by pump. Next slide. Vagus nerve stimulation is the only existing device for epilepsy that's approved, and it has a development plan in many different directions, which you can see, including, I think most interestingly, a protocol that they're thinking about to automatically trigger the magnet stimulation mode based on an increase of heart rate that happens at the start of many people's seizures. Next slide. I'll skip this one. Next slide. And then the last technology to mention is deep brain stimulation. It's kind of like vagus nerve stimulation, but instead of stimulating the neck, it puts wires deep into pacemaker central areas of brain and stimulates, in this case, 1 minute out of every 6 minutes on a cycle because the effect's lasting and that saves the battery. And the chart shows that the line in green, the circles, had 40% reduction in seizures versus fake stimulation for 3 months, which had only 14.5% reduction in seizures, and that difference was statistically significant. And then there's another stimulation trial, next slide, which is called the NeuroPace trial. Next slide. That detects a seizure and then countershocks to respond to it, but overall had very similar results with about a 40% improvement. Now, on the basis of that trial, brain stimulation was approved in Europe, but the US FDA is slower, more conservative, and they're saying they still want to see more data, et cetera, et cetera. So it's not available in the United States. Last slide. That last slide's kind of a joke slide. This is the last real slide. Trigeminal nerve stimulation is like vagus nerve stimulation, but stimulates a superficial nerve over the eye that's easier to get at. And it seems to be showing good promise, not just for epilepsy, but for depression as well. And one of the nice things about it is you can stimulate over the eye with a patch on for a few months to see if it's working before you actually have an operation to implant it, something that can't as easily be done with vagus nerve stimulation. So those are some of the things that we do now and are around the corner. And I'd like to turn now over to Bree to give a little bit more of a real-life sense of experience about how you go about making decisions to have some of these things done. Samantha, I'm sorry. Samantha, not Bree.
Hi, I'm Samantha. I'm 27 years old, and as Patty said, I'm from Wisconsin. So I've had epilepsy most of my life, pretty uncontrolled. Had it since I was 3. And it was pretty bad most of my life, but I got married, I was 21, and it got worse. I blamed it on my husband. So a pretty blunt doctor told me, you can either have really bad seizures and live with that and not have kids ever, or you can have surgery. So I chose surgery. And about 3.5 years ago, I had, and I'm going to put this in my terms so you guys can understand it, because doctors never say it, so we can understand it. I had 2 grape-sized pieces removed from my submotor cortex. And since then, I've been able to have 2 beautiful children. I have a 2-year-old boy and an 8-month-old girl. And I've been able to get my driver's license, and my life pretty much has made a complete change. I mean, I don't think there's a day I'm not grateful for what I've been able to accomplish. So that's my story.
Before you ask me questions, would you say a word about the notion of having children or not having children?
Yes. And I want to come back to the decision-making process. Decisions of having children is always such a tough one, and 9 times out of 10, half the women are not even know that might be an issue. Sometimes till too late. And over 90% of women are going to have healthy children and can live with seizures and having children. But there also comes a time when every woman needs to think about it. All parents need to think about how might my seizures make it difficult in being a parent, and so how do I weigh all those pros and cons of doing it, like Samantha had to do, is, how will my seizures really get in the way of that? And then there's that other issue of if I can get my seizures better controlled, can I get on less medicines, or might the risks of medicines during pregnancy be better? So those are some real complicated things that everyone needs to think about at some point. And when you're faced, I think, like Samantha was, at a crossroads in her treatment of saying more treatments, different treatments, trying surgery, that's when all of these kind of key issues come to life, at least from my thought. So I want to pose the first question to Samantha. As you're making these decisions, was that the biggest thing, and how did you weigh that, and what other issues might have come into play as you thought about going forward with surgery?
Was kids the biggest issue?
Yeah, and what other factors might go into play?
What family? well, family did play a big part in it, but I was having daily seizures, and I just was not living a very proactive and, like, it wasn't the life I wanted to lead. You know, like, I wasn't doing anything. I mean, I was going to work every day and doing what I could. I was an event planner, and I went to work every day still after daily seizures and nightly seizures and everything like that, and I did what I had to do. You know, I wanted to, you know, go to work every day and, you know, be productive, because you don't want to not be normal. What's normal, actually? But, you know, you don't want to be the person with epilepsy. You know, like, you don't want that label. So I went to work every day and then came home and had seizures. And that was my life. But I didn't want that life. I wanted kids. You know, my husband and I wanted kids. And I couldn't have that until I had full control.
Did you think about the risk that something might go wrong during surgery?
I did.
How'd you handle that?
Not very well. Want the truth? That's the truth. There was only a 50% chance I would be seizure-free. And that was a better chance than what I had. So, and I got lucky, and I came out with 80% chance of seizure freedom. So, and since that day, I've been pretty much seizure-free, except when I was pregnant, and then I was not so seizure-free.
So one of the points that Samantha raises that I'm going to throw back to both of you is that, you know, the thought of going through surgery isn't like, okay, they've mentioned it, yes or no, and I'll go forward with it. There's a long process of trying to sort out, is surgery appropriate, you know, what kind of surgery, where are my seizures coming from, and all the counseling and preparation of the individual, their family and stuff that kind of goes into that. So what Samantha just said that rang, you know, important to me was that when she started the process, they said, we might only have a 50% chance because of the area of the brain where her seizures were coming from. Yet after going through that extensive work and some real complicated stuff, then she was able to get better statistics of now should I go forward and kind of make that ultimate decision of having the surgery. So it's not a cut and dry scenario of this is what I can do, these are my statistics, I'm going for it. Do you want to add to that, Dr. Fisher, and then Samantha?
Sure. I would be extremely comfortable pressuring any of my patients to have surgery. Epilepsy surgery is always elective. Now, if you have an underlying cause like a ruptured blood vessel or a tumor or something else that needs treatment, that's a different story. But if the goal is control of seizures, nobody should ever tell you you have to have surgery. I have people who have many seizures. They might be good candidates for surgery, but they don't want surgery, and that's their right. You know, they take the risks of epilepsy, and we've heard about some. So it ought to be a discussion, and doctors and nurses ought to give the patients the information, and you make the decision in conjunction with your family. I obviously wasn't there, and I'm not your doctor, but it sounds like although things worked out well for you, you may have been put on the roller coaster heading towards surgery a little bit more than you were ready for.
I was asked several times before, like years prior to, and so I do think it was a last option for me. I had been through the medication. You know, the VNS wasn't an option. The diet wasn't an option, because who wants to go on the diet at this age? I mean, come on, let's be serious.
Wait till our diet talk later.
You know, you're in your late 20s, and you know you don't really want to change your diet.
Right.
But surgery, I had already thought about it, but when I got the option, it was a reality. It was like, okay.
Did you feel pressured, or was it your choice?
It has to be your choice. You have to make the decision. It's a personal decision. You can't let anyone else make the decision for you.
I agree.
It has to be your decision.
It's not the doctor's decision.
It can't be your family's decision either.
Right.
You have to make it for yourself.
Right.
So.
So if anyone from the audience has questions, please step up to the mic. And could you actually move the slide forward one? You know, Samantha had listed out some things. I don't know if you want to speak to it, of kind of things that were helpful to you. They might sound very simplistic, but it's critical.
Yeah. I mean, I listed coloring. It was so, like, it just was stress relieving. Like, sitting there and in a big coloring book just coloring. I mean, you might think it sounds really stupid, and it probably, you're probably like, why? But it was the most, serene moment of the day. I'd go home and color. I mean, it was just so simple and so relaxing. And music was a huge part, and so was writing. I mean, writing really helped me I was mad. I was mad. I was depressed. It was not fun. The testing process was not fun. It was long and drawn out, and I was mad.
Yeah.
Was this before or after your surgery?
This is before.
Okay.
So
let me go to people at the microphones, right in the middle here.
I just have one real quick question. After your surgery,
yes,
did you need to take medication?
I'm still on 2 medications, yes.
Okay.
Twice a day.
I'm on a considerable amount, and I was, I'm on 5,800 milligrams of medication.
I'm on a very low dose compared to what I was on.
Very good.
And that's a common story. Some people can get off medications. The medications now work where they didn't before. And there's some people where maybe a couple of years after surgery, they could get off medications, but they're driving, and they don't want to risk having a seizure, so they just stay on them.
Over here.
Can you speak to the age? At what age should people start thinking about, operation? Are we 5 years, 10 years, 15, 20?
Do you want me to take it?
Yes, go ahead.
There is no specific age limit. When I was at the previous hospital, we did epilepsy surgery on a 4-month-old baby. The mother knew there was something wrong in the womb, could actually feel the seizures happening in the womb. But something like temporal lobectomy, the kinds of operations we're talking about now, normally wouldn't be younger than childhood, but it's certainly the case that 5-, 6-, 7-year-old kids can sometimes benefit from epilepsy surgery if you're sure that the meds aren't working for them and that you know where the seizures are coming from.
Okay. Do you have a quick follow-up?
Advantages of having these operations at a younger age, or?
Yes, years without epilepsy.
Right. And years without the effects of epilepsy on the way a person thinks and feels and moves.
And the effects of the drugs that dull people down, unfortunately, and have problems. It's not my job to sell epilepsy surgery. I'm, in fact, not the surgeon, the diagnostician. We get no finder's fees. Those would be unethical. But I do think that people, including doctors, just wait way too long to consider that as an option, and people have many wasted years.
Okay. Right over here, please.
Yes, I'm just going to let you know I had surgery as well. It was back in May, so it's been 9 months now without any seizures. But it was interesting. I want to hear your reaction.
Congratulations.
Oh, thank you. I want to hear your reaction because for me, with the surgery, I was tense or I was stressed out. But I think my husband was more stressed than I was. What was your reaction or what happened in your case? Because I'd like to hear other people's reactions to that.
My family went crazy. It's true. They spent so much time in the hospital. They did. I feel for them because I don't remember a thing, and they remember it all.
Yeah.
Yes.
So I feel for them because I'm like, so what happened?
Yes.
And they have to relive it every time I ask what happened. And that's got to be hard.
Yes.
This
Probably
brings...
feel the same towards your seizures. You don't
Yeah,
remember them,
exactly.
but they sure do.
The family almost has it harder. So at times I feel like they have to watch us go through this. So it's almost like they should probably go see someone about it sometimes. Like, honestly.
Well, she's just touched on an important part, because epilepsy is a family affair, but it affects families differently than people with epilepsy. And ideally, when you're making big decisions, that whole family unit should be in on those discussions and have their own, supports or counselors to really kind of think about, their reactions to it, because everyone's got to kind of be on the same page. Because I think, as Samantha said, having that friends and families together going through something like this is critical to success.
Well, I had to go to therapy, but I think my family should have gone to some too.
Fair enough.
But I'm saying that they should have probably gone too, because they needed someone to talk to as well.
Thank you.
Okay.
Right in the middle.
Oh, hi.
We got time for just a couple more questions.
I was wondering, would you share with us what type of seizures you had, and before your surgery, were they able to identify a lesion or a focal point?
I had tonic-clonics, complex partials, and that was it, sorry. And
That's enough.
it was enough. They had to do grids twice, and they found mixed up blood vessels. So.
Yeah. All right, good point.
And
last question over here.
One of the scariest parts, like having epilepsy and thinking about surgery, is what if I'm not the same after? Life is hard right now, day to day, but what if I'm not the same after that surgery?
That was a big concern.
And that's so it helped you, but what was that deciding decision?
Go ahead, Sam.
That was a huge
better
concern.
phrase it,
But I don't think I've changed at all.
Yeah, I think that there's a number of different answers to that. And one I might say is, if I don't have surgery, will I be the same, and what's going to happen down the road? And when you're having brain surgery for epilepsy, you're generally, I don't know how to say this might not sound right, kind of in the safest hands, because they don't do it emergently. Like if you fell and had a trauma, or you got a brain tumor and they got to go in and do something then, they don't know as much about your brain as if you go through a surgical workup. They're doing all your EEGs and getting tons of scans of your brain, and you're having neuropsychology testing to know, what parts of the brain do what. So the surgery is really tailored to try to avoid, problems arising. With that said, anytime someone gets anesthesia, someone operates, there are always those risks. But those risks of surgery are much, much smaller than one thinks. All right, that's my first point. Go ahead. My last. I'll let him take the last.
Most people who, in the public, who think about surgery see Jack Nicholson in One Flew Over the Cuckoo's Nest, frontal lobotomies. It really isn't like that. If something happens like that, I put that in the category of the 1 out of 50 chance where something seriously has gone wrong. There are different types of brain surgeries, and yes, there can be problems, but the hope and the expectation is after surgery you'll be better in many ways, although it isn't just a one-dimensional better or worse, because the realistic answer is you'll be better in some ways, but you may have even more trouble, for example, with a left temporal lobe surgery coming up with that tip of the tongue word. But in every other way, you'll be better. So this is something that you'd have to individualize with where the seizure focus is, what the operation's going to be with the doctors who are going to be working with you. And after that discussion, if you don't feel on balance, I've got at least a better than even chance, hopefully way better, of coming out of this better off than I am now, don't do it.
All right. Thank you for all of the great questions, and thank you very much, Samantha and Dr. Fisher.